Hello, everyone. Thank you for joining for this evening's careers webinar, which will be focusing on histopathology. I'm Penny Fletcher from the Royal College of Pathologists, and we have two speakers who will be introduced shortly. Just a really quick note about the college. So I'm sure you realise that we're the Royal Medical College for Pathology, and that is actually across 17 different specialties. So please do check out our website for all the careers information. And I'm really pleased to be starting this series with histopathology, which represents about 50% of our membership. I'm going to hand over to our two hosts, Zainab Shafiq and Rosie Walsh. Thank you.
Yeah, thanks, Penny. So hi, I'm Zainab. I'm the UCL Medical Society Pathology Chair, and our pathology division is quite new, so we're quite keen to increase the number and diversity of events. So we were quite lucky when Penny reached out to us wanting to collaborate, and I told her I had an idea for kind of having different pathologists come in and give talks, and she suggested turning it into a careers webinar series nationally. And she also introduced me to Rosie, who is really happy to get on board with that, and hopefully this will be a really good series.
Yeah, so hello, my name's Rosie. I'm the president of the new University of Manchester Pathology Society. We were very, very excited to get an email about this event and then to get involved with a collaboration as well with all the UCL Medical Society for Pathology as well. So it should be a really good event series, and we're very excited. The two talkers we've got today are Dr. Aneeta Jassar and Dr. Stephanie Edwards. They're both consultant histopathologists, and they both had very different journeys to get to where they are today. And their talks should be really interesting about their career and their journey into getting into pathology as well. So the first speaker is Dr. Stephanie Edwards.
Hi, my name's Stephanie Edwards. I'm a consultant histopathologist at Manchester Royal Infirmary, and I'm just going to talk to you today about careers in histopathology. So I thought it would be a good idea to talk a little bit about what histopathology actually is. I mean, obviously, if you're here tonight, you've already got some idea, so it is possibly preaching to the converted slightly. But essentially, pathology is the study of disease. And I got this lovely definition from our RCPath, Royal College of Pathologists website. It is the bridge between medicine and science, underpinning every aspect of patient care, from diagnostic testing and treatment advice to using cutting-edge genetic technologies and preventing disease. Now, as we briefly highlighted, there are an awful lot of subspecialties in pathology, up to 17. I'm only going to be talking about one of them, and it's the one that I work in, and that is cellular pathology or histopathology. And this is the study of diseases of tissues and cells. And what we really do is essentially it boils down to that we are responsible for diagnosing and studying disease in tissues and organs. So what that really means is that anytime, for example, a biopsy sample is taken in a hospital, it's our job to look at that and to give the referring doctor an idea of what might be going on. Now, one of the interesting things about picking a career in histopathology is that I don't think it's fantastically well advertised. Certainly, in my experience when I was a medical student and even as a junior doctor, I really didn't know much about histopathology or what pathologists did at all. And there's quite a lot of misconceptions that go along with being a pathologist. These are some of the commonest misconceptions that I've come across, strangely, even from other medical colleagues. People wonder, are you actually a doctor? To which the answer is yes, we're medical doctors. Some people wonder if there shouldn't by now be some kind of clever, amazing computer program that does what we do. And unfortunately, we're not quite there yet. And the other misconception that I think a lot of people, definitely more in the general public, have is, isn't it just doing autopsies? I think they think that we spend a lot of our spare time solving crimes. And it's nothing like as dramatic as that. But I'll come back to some of these misconceptions and hopefully address a lot of these later. But to start off with, I just thought I'd talk a little bit about how I got into histopathology, how I eventually became a histopathologist. So I did my undergraduate training in Sheffield, and I graduated from the University of Sheffield. I then went straight into FY1 and FY2 and did my general jobs, doing a little bit of surgery, orthopedics, and a little bit of medical education as well. At that stage, I was very, very fixed on wanting to go into surgical training. That was what I really was interested in doing. I spent a lot of my time at medical school exploring various medical specialties and deciding what I didn't like rather than what I did. I had some very enthusiastic friends who seemed to enjoy everything, but I was very much more interested in kind of practical hands-on things, and at that stage I very much wanted to do surgery. I spent a little bit of time in core surgical training in orthopedics and plastic surgery before I lit on ENT, otolaryngology, which I really, really enjoyed. I liked the kind of fine motor and the technical aspects of that. The anatomy was quite complicated, but in an enjoyable way. And I really liked how, as a junior core surgical trainee, I could do a lot of small practical procedures on the wards and things. I then had a locum appointment for training post as an ST3 in otolaryngology. And this is kind of where I think I went off the beaten track a little bit. At the time when I was doing my training, there was a big shortage of surgical training jobs, and a lot of my training cohort, we all kind of had to think about backup ideas for careers. And also at this time, I was starting to wonder if I'd made the right choice. I'd really gone into surgical training. I don't really want to say because I hadn't come across anything better, but I think that is really true. I did enjoy it, but the more I did it, and certainly the more senior I got, I really started to struggle with the amount of out of hours work, and also the need to be kind of constantly buffing your CV. You can do kind of like papers and audits and things like that, just to get enough points on your application form to get to the next stage of training. It was frankly exhausting, and I just really wasn't happy. And I was looking at a lot of my senior colleagues in that specialty and noticing that they didn't really seem very happy either. At this time, I was working in Plymouth, and we had a really good relationship with our pathology team there. So our multidisciplinary team meetings on the Thursday morning, the pathologists would come in person to that, because this was pre-COVID days. And the consultant pathologist who would also come to clinic afterwards was very, very nice and very friendly. And I just got chatting about what the career involved. It just looked quite interesting. In the clinic that we had after the meeting on a Thursday morning, we'd have patients with acutely presenting neck lumps come in. And in that one-stop clinic, they would see a radiologist and get an FNA, get a fine needle aspirate of the lump. And then the pathologist would actually look at the slides in clinic and give a very, very kind of rough idea of, is this malignant, is this benign? I mean, I now know from experience that it's very hard to give that kind of diagnosis in that setting, but there are some cases where you can give a better idea of how quickly to prioritize people. And I found that fascinating. I found that really interesting. So I started to have a bit of a chat to him about careers in pathology, and it turns out that he himself had been an ex-surgeon. He'd been a general surgeon, and a lot of the surgical trainees he knew had gone into either radiology or pathology. So they invited me down to the department and let me come and see what they did, and it was fascinating. And the thing I enjoyed more than anything else was seeing these pathology trainees who actually had a life outside of work. A lot of them had hobbies and things, and I thought, oh wow, this is what life is supposed to be like. It's not supposed to be, constant work. So I made the decision. I switched over to histopathology, and it was the best decision I've ever made, because I've absolutely loved my career ever since. I then did my histopathology run-through training in the Northwest, in Manchester, and went through that, got my RCPath and my consultant post. So in a summary, I would just like to say that sometimes you think that you have an idea, you work towards something, and it kind of, you follow the steps and it happens. But you know, life isn't always like that, and sometimes kind of things pop up that you know, can either get in your way or can, you know, give you other opportunities. And I think it's important to remember that, you know, your career isn't necessarily going to be linear, and just to remember that, you know, that's fine, that's okay, as long as you kind of get where you want to be. I just want to talk a little bit about what I would maybe do in my typical day. So this would be the official spiel of what I would do. So the bulk of my typical day is reporting, and that's obviously generating the histology reports for the cases that we see. And that involves looking at the cases down the microscope, deciding what I think it is, you know, weighing the benefits and the pros and cons of the diagnosis, and deciding if it needs any extra testing, writing the report in a way that conveys all the important information I need the surgeons to hear, and then making sure that the report is authorised and finds its way to the right person. We also do what's called cut up, and that's where we actually work with the surgical specimens, and that, to be honest, is one of my favourite parts of the job. I actually really like still being quite hands-on with cut up. I specialise in head and neck pathology because of my previous background in ENT, and our specimens that we get are quite big and quite complicated, and I really enjoy that. So what that means is that I will receive the specimens from theatre, and that can be something as small as a piece of skin, or it can be something as large as a larynx, or even, you know, sometimes a jaw with a tumour and tongue attached and things like that. And we fix that in formalin, and then when it's ready, we look at it in the lab. We decide how to slice that up in the way that's going to give us the most information about the tumour and the surgical margins. And it's that kind of approach, that kind of 3D reasoning and working it out, that I actually really enjoy. Spend quite a lot of time consulting with colleagues. You know, if you have a difficult case, there's always lots of people around still to ask. In our department in Manchester, we have our ST1s, our first year trainees, and we also have senior trainees as well. So we have quite a number of trainees in our department, and it's always really enjoyable to teach them as well, either practical hands-on stuff in cut-up, or on the microscope on a multi-header, so we're both looking at the same case. We also have our multidisciplinary team meetings with our surgical and radiology and oncology colleagues once a week. And there's quite a lot of preparation that has to go into that. So that's the official summary of what we do every day. What I actually do every day is a little bit different. It's a lot of puzzle solving. So some cases are straightforward and a lot of them aren't. So not knowing what something is fine. It's knowing what to do about it. That's the trick. So I can look at a case and think, oh God, I've got no idea what this is. Well, how do I find out? And that's the thing. It's okay, well, what further tests do I need to do? You know, I need to have a look at the patient's history, see what they've had before, things like that. What resources can I use to work out what this disease process is? As I say, the cut up in the lab is actually really enjoyable, because we get to see some really, really interesting anatomy, and it's really nice to, you know, you get taught it in a textbook, or you know, if you're lucky to be at a school where they do kind of dissection or prosections, but actually being able to pick up a specimen and kind of turn it around and examine it from all angles is something I never imagined being able to do when I was a surgeon. So that's really gratifying. A lot of chatting with colleagues, chatting with consultant colleagues, chatting with lab colleagues, you know, checking how things are, how are things getting on, how's the workload in the lab going, catching up with trainees, how are they getting on with their exams and things. And then also just following up about the patients as well. I find that really interesting. You know, we've got some really good computer systems in our hospital, so we can look at the patient histories, or I can also have a chat with my surgical colleagues, and it's important to kind of keep good communication lines open with your surgical colleagues, because sometimes you'll get to know a lot more information about a case than has been supplied on the request card. So that's really what we do. So I suppose the main thing to ask is, why would you want to be a pathologist? And this is coming back a little bit to those negative stereotypes that we have about the specialty. I found this absolutely excellent article online in a publication called The Pathologist, where they called the pathologist the last respite of the socially inept. And you have this kind of classic image of the kind of scary, creepy, mortician, technician, pathologist person. And it's really not like that. It really is. It's much more social, and it is much more technological as well. So some of the common misconceptions would be things like pathologists don't like people. Well, that's not true at all. Although we're not frontline, we're not seeing patients day in, day out, there is still a lot of communication, but also we are very, very aware that the work that we do is it's patient-centered at the end of the day. So at the end of every biopsy, at the end of every report that we write is a patient, and we are very, very aware of that. So it's not that pathologists don't like people at all. A lot of pathologists are very, very social. And also we're still very, very mindful that we've got, patients around who we are, caring for, even if it is a little bit more removed. Along with that goes with this idea that pathologists don't really have very good communication skills. And I wonder if maybe that's a hang up from the bad old days. Maybe in the past that might have been the case. But now we are so heavily involved in multidisciplinary team discussions. It's really, really important in pathology to have good verbal and written communication skills. So not only do you need to be able to write reports that tell the surgeon what the diagnosis is, a lot of the time the reporting will be also kind of subtly letting them know the severity of the disease and giving them ideas about whether, is this something that needs another biopsy? Is this something that should really be excised? So there's a lot of kind of subtle communication in the reports as well. And then again, keeping really, really good communication lines with your clinical colleagues is really important. Certainly I'll regularly have chats with our team radiologist about cases. That's actually really, really helpful, and it really helps you to formulate your reports. And it's also just quite satisfying to know that you're all working together to get the right answer for the patient at the end of the day. There's a misconception, certainly amongst some of my non-medical friends, that pathologists just work with dead bodies. Very much not true. All of my specimens are from living patients. All of the samples that I deal with are from people who are waiting for the results of that report. Histopathologists do partake in post-mortem work. That's something that's optional as part of your histopathology career. When you are a junior trainee, you'll do post-mortem training for the first 2 years. But then after that, you can decide if you want to keep doing that, working with the coroner, or if that's something that isn't really up your street, not something you want to do. So post-mortem work is really important. It's really important to get that information correct for the families of the bereaved. But the majority of pathologists do not have anything to do with working with dead bodies. I think the last misconception is quite an interesting one, which is that pathologists are very nerdy or geeky or a bit weird. I probably can't speak for being a bit weird. I fully admit to being a bit weird. But in fact, of pathologists being a bit nerdy, it's quite an interesting one. Certainly when I was at medical school, I had friends who were very, very academic. They were very into research, really, really kind of like intimidatingly clever. These are not the people who have gone into pathology. I mean, some of them probably have, I'm not sure. And actually, I must admit, when I was looking at pathology as a career, I had that misconception. I was a bit worried about that. I genuinely thought I might not be clever enough to be a pathologist, if that's the right way of putting it. I thought that there was going to be an awful lot of quite high level biochemical science that I was going to need to know that I hadn't ever really managed to quite grasp at medical school. But it's really just not the case. If you are so inclined, if you are a very academic, research-minded person, that's brilliant. There's loads of opportunities in pathology for if someone is research-minded and is interested in that kind of thing. And that's where a lot of our new developments in particularly molecular pathology and personalised medicine are coming from. But there's also a lot of room for people who are a bit more practical, a bit more hands-on, and people who enjoy teaching a bit more. I think pathology is a very, very broad church, and actually we need people of all kind of personality types and backgrounds to really make it an effective service. So everyone is welcome. So why is pathology so great? Why am I raving about it so much? I do genuinely think it is medicine's best kept secret, in that I think the knowledge of histopathology as a career is very badly advertised. I think a lot of medical students, because you guys don't necessarily get to come to your local pathology departments, you don't get placements in histopathology departments, you really don't know what we do day to day. And hopefully these talks today will go a little bit towards addressing that. Part of the reasons why histopathology is so good is you can organize your own time. So the work is busy, but you can really prioritize what you think needs doing first. So you're not tied to times for clinic, you're not tied to times for theatre. You can kind of think to yourself, okay, this case needs doing, this case can wait until after that case is done. Along with that, the working is fairly flexible as well. For example, if you've got childcare commitments or something like that, you can come in early and leave early. It's very easy to kind of time shift as well. And hopefully in the future, with the development of digital pathology, there's going to be much more opportunity from working from home, I think, as well. So that I think that's going to be attractive to a lot of people. There's a huge amount of variety in histopathology. A lot of histopathologists will focus on one or two organ systems, but some stay general pathologists and will just report everything. So you can become super, super specialised, or you can stay general. And there's lots of opportunity there. As I was saying before, it's very, very easy to get involved in teaching and research because you have got less kind of clinical commitments, and because the work is a bit more flexible, it is easier to kind of fit in time for those just extra things that just keep your career interesting. The day-to-day job as well, it's very satisfying in the sense that you're solving problems, kind of like solving puzzles. So for the type of person who likes solving puzzles, who finds it very satisfying when you finally come up with the right answer after all the hard work, then that might be the job for you. And it's although you are a little bit removed, it does still have that direct impact on patient care and management. So at the end of the day, it does still feel really, really worthwhile. So I think that's the end of everything I've got to say. So I'll just say thank you very much, and I'll just hand over to our next speaker.
Hello, everybody. My name is Dr. Aneeta Jassar, and I'm a consultant at the Queen Elizabeth Hospital in Gateshead. And I feel really privileged today to be talking to all of you about something that I'm very passionate about. And I hope I can kind of transfer some of my enthusiasm to you and convince at least some of you at the end of the day to consider a career in histopathology. So Steph has done a wonderful job of introducing pathology and histopathology to you all. And just to give you a bit of a historical perspective, Steph talked about how she finds it easy because of her surgical background to kind of correlate what she sees on cut-up with what she thinks the pathology could be. And this is not unusual at all. And it was this Italian physician, anatomist, and pathologist from the 18th century, Giovanni Battista Morgagni, who actually thought about this first. And hence he's considered the father of modern anatomic pathology. So what he did was basically he tried to he did correlate postmortem pathology with clinical findings that his patients had, and thus established pathological anatomy as a science. So herein comes the significance of doing postmortems and going in with that very scientific kind of approach towards postmortems, because you're actually going in there to kind of find out the cause of death and kind of help the family reach kind of emotional closure in many ways. So it's a very important contribution that you're making by doing a postmortem well. So this gentleman is known for that kind of precision in his dissections, in his writings, and he determined that diagnosis, prognosis, and treatment of disease can actually be based on an exact understanding of pathological changes in anatomical structures. And that's where the word anatomical or anatomic pathology comes from. So histopathologists kind of, we would like to think like we are the Sherlock Holmes of the medical world. Steph mentioned about how it's so much about kind of puzzle solving. And it's true, because you will be called upon to have keen observation skills when you examine tissue macroscopically as well as microscopically. You will be expected not to miss out any clues, any dual pathologies, any incidental findings, etc. And it's all a very visual science in that you need to have good pattern recognition capabilities to identify things, identify when it's normal histology, it's metaplastic, reactive to, is it neoplastic? And if it is neoplastic, is it benign or malignant? So that those kind of things, you need to hone your skills on that. And then many a times, or most of the times, we have to connect the dots, which is correlating the clinical information, the pathology, and the radiology, which is what we do during our MDTs. And many a times, for instance, you get clinical information on the form that says coarse microcalcifications in the breast, and you don't see those microcalcifications under the slide. You need to think laterally, need to go after the calc, go and kind of x-ray the block to see if that specimen has the calcification, and if not, then put it up to your clinical colleagues and say that, you didn't see the calcification, so is this tissue really representative of what we are looking at on radiology? So things like that, you need to have those skills to connect everything for the patient's benefit at the end of the day. And of course, we have many tools in our armamentarium that can help us confirm a hunch that we might have, for instance, using immunohistochemistry, molecular techniques to confirm our diagnosis, which is difficult otherwise just on H&E slides. And I would highly recommend this book, which I myself loved reading, The Emperor of All Maladies, Biography of Cancer by Siddharth Mukherjee. And it's kind of such an interesting read for anybody who's interested in not just pathology, but kind of the entire history of cancer and how far we've come from the age of the Egyptians when they would cut off breasts with cancer, with swords, down to the precision medicine era that we are now in. So it's a fascinating read and I can't recommend it enough. So my own personal journey has actually been a bit of interesting, full of variety, and it's actually also across continents in a way. So I started out here at the Armed Forces Medical College, which is a very unique and also very prestigious medical college in India. And it's unique because it kind of has it's an academy which makes us into officers when we train as doctors together. with training for military. So it's kind of a very unique academy in that sense. And the Indian government actually took out a stamp in its honor on its 50th jubilee. And it's recently celebrated 75 years. And it, our alumni actually boasts, of medical officers in uniform, including many lady officers who are generals and doctors wearing those two hats at the same time. So a very interesting place to actually become a doctor in. And then I was in uniform for 22 years. And again, it was a fantastic journey because I was not really like just doing histopathology, because I was actually like a very broad pathologist. So I was responsible for arranging for blood, making sure blood transfusions are safe, doing microbiology, so many things. So I kind of served in low intensity conflict areas where in Jammu and Kashmir, I was actually called upon to do the very unpleasant task of kind of putting together bodies that had been shredded by IED blasts. And we kind of worked through the night and got it all together so that the loved ones could see and receive the bodies, in some decent form. And then I was fortunate enough to kind of have a brief 1-year stint at the Democratic Republic of Congo, where India has a level 3 hospital in Goma. And it was a very unusual and interesting and a little disturbing kind of a tenure, because the kind of very limited resources that were there. So we went to help out in a local hospital where they had no histopathology facilities. And we actually used to kind of do, the tumor used to be out of the body, and we used to do cytology on that tumor. Just tell the surgeon about what we thought it was, like how badly malignant or likely to be aggressive it was. So something like that, you had to really kind of innovate and do the best you could. So yes, it's been a very interesting journey for me. And then I decided to come and join the NHS. And here, of course, it's mainly histopathology that I do. So just to give you Steph has already given you an introduction into histopathology. So it's basically the tissue has to, once it's out from the body, it needs to come under the microscope, where a pathologist can kind of make a diagnosis of what it is. So it goes through these steps of cut up by the pathologist, where you end up kind of inking the relevant margins, taking the relevant measurements, and actually taking small bits of tissue which you think are the most relevant to diagnosis and putting them into wax. And then those are cut into very thin sections, which are then stained, because obviously you can't see it if it's not stained. So we use hematoxylin eosin that makes our slides pink and blue. So we are the pink and blue doctors. And then we make sense of that pink and blue as best as we can under the microscope. So my typical day on the surface is doing cut up. We have excellent macro tables and photography available to us, and we can later look up these photographs from our computer screens and kind of refresh our memory about what the tumor looked like on slicing when we are looking under the microscope. So we do all of that, give a good decent description, and then make sense of all that pink and blue under the microscope. And many a times we need to discuss the difficult cases with our colleagues. And then once we have kind of made up our consensus diagnosis on difficult cases, we need to present those findings at the MDTs, where there are other colleagues, our clinical colleagues, radiologists and all, where then all of it has to come together for the patient and management decisions are taken. So that's the surface. And actually, the day is actually, it's not as peaceful as it seems on the outside. It's actually an array of emotions that a pathologist goes through. So that's the inside story. Euphoria, if I, get it right, a difficult diagnosis, immunohistochemistry helps me and I kind of reach a diagnosis, happy, or my senior colleague is happy with my report, nice. But again, while driving back home, I'm like, hope I didn't miss anything on that case. Did I mention everything that I was? Did I check on the data set and didn't miss out any core items to report? And then once, or, maybe a little more than that, in a week, I have no idea what this is. I need to get an expert opinion. And all of us are working under a lot of pressure in the NHS. So definitely a lot of pressure of time. Need to update is always there because pathology, like other branches, is actually moving at such a fast pace. We need to keep up with all the genetics and how to send the tissue away, where to send it. So much to update oneself on. And of course, the need to have coffee and holiday is there every week, I think. But there are some misconceptions. Steph has covered most of them. I thought I'll take a minute and, say something to this effect, that you think sometimes that we hide behind a microscope and we are not involved in patient management, but that's not true. Histopathology practice is very patient-centric. We are aware at every moment about everything that we say and how it's going to impact the follow-up and management of the patient. And at all MDTs, histopathologists play a very active role in, giving their input into the patient management. Pathologists don't get respect. That's not true. It's, up to us how much we want to actively kind of give our input to our clinical colleagues. And when we do that, it's really respected and we definitely get our due. Do we work in isolation and in isolated locations? Not true again. The location might be isolated, but we are, with technology, never really isolated because we have our MDTs on Zoom. We regularly communicate through emails. And, our radiology colleagues sometimes even come into the department to discuss things. So things like that, it's never in isolation. Will AI replace us in the future? Well, who knows? The future is uncertain for all fields, and who knows what will happen? And maybe they won't need doctors at all in the future. We'll all turn into cab drivers, or they won't need those either. So that's uncertain. But definitely, histopathology has a lot to contribute to medicine. It's not just, diagnosis, which indirectly gives prognosis for the patient. So we kind of give grading and staging. We tell the clinicians whether the enlarged node that they felt, does it have metastatic tumor? Is the pleural effusion that the patient is getting, is it reactive, or is it actually because of the breast cancer that she had 10 years ago? So things like that. It's all like very important diagnosis that's going to impact so much on her prognosis, on her or his future quality of life. It's also prevention. So the NHS has national screening programs for the breast, for colorectal cancer, and for cervical cancer, and histopathologists are very actively involved in all of that. And we need to update ourselves and remain accredited to take part in those. Our input definitely guides for the follow-up and management. To give you an example, if a lady has an abnormal cervical smear and then ends up having a cervical biopsy, and we depending upon what we tell the gynae or the colposcopy MDT, depending on that, she will have either just follow-up, or she might end up having a cone biopsy of the cervix or a removal of the uterus, etc. So all those decisions, very important decisions, are kind of made by the histopathology diagnosis. And we have now molecular testing, which is like so going to it already has, and it's going to revolutionize medicine even more. So for all, like, for instance, for all breast cases, we will do genetic testing for, HER2, and then that will tell whether this patient is going to be eligible for certain immune therapies or not. And if, we detect certain syndromes in the patient through genetic testing, then that might determine whether further genetic testing is mandated for other family members who might be at risk for similar cancers. So all that, like, so important. And that's why, no doubt, the Royal College of Pathologists logo says pathology, science behind the cure. It really is. So why should you choose histopathology? And like Steph said, this is where we sell histopathology to you. And I have these kind of following options to present to you for choosing histopathology. You can listen to your favorite music while working. Well, true, you can, because you are going to be with your microscope and your slide, you can put on your headphones. But on a serious note, it's really about flexible working and a good work-life balance. So you can very well have flexi hours as long as you do your allocated work. You can kind of leave early, come in early, things like that. You can work it out with your clinical leads. There's such good integration of technology into pathology. It's quite a pleasure to kind of, like I said, we can take pictures of the tumor, at the cut-up table, look at it from our desk, do our MDTs from our office, dictate our reports, and then use the software to kind of dictate our reports, and we can now even share. So all the slides, there are some cases which we can scan, and the difficult cases, those are the ones we can annotate, we can share with our colleagues, ask their opinion. And there are ample opportunities to develop subspecialty interests like cytopathology, autopsy pathology, and then, of course, any other system that you would like to go for. Like Steph is doing head and neck, and my interests are breast and gynae pathology. So there are ample opportunities to develop those. There are excellent resources available for continuous professional development, including many resources on the RCPath website. You have opportunity as well as the time to get involved in research, clinical trials, teaching. So because I found the fellowship exam quite challenging as an international medical graduate. But when I did finally finish it, and I started teaching other colleagues from India, and about how the practice in NHS differs. So the practice does differ from country to country depending upon what exactly is the epidemiology of things. But it's very satisfying to kind of be able to teach trainees and other FRCPath aspirants, and I've got the opportunity and the time to do that. There's a excellent, vibrant international community in histopathology. And so there are multiple opportunities to collaborate and travel to Europe, to America for USCAP. And there are ample number of bursaries available to do that. They're fairly transferable professional skills in histopathology, which is to say that if you do decide to kind of, move into another continent or a country, so it's not so dependent on a kind of language so much. So you can kind of easily integrate into another country and culture, not that difficult. The future holds promise of remote working in histopathology. So imagine being able to work while lying on the beach in the Bahamas. So that's a distant dream of all histopathologists. And what does the future hold for us? So digital pathology is what I was talking about, scanning slides, and this technology is already being introduced into many NHS trusts, and we have it too. So we are all in the process of revalidating and looking at glass slides as well as slides on our screens, and then seeing how good we are at picking up stuff. But in the future, it's only going to get better and better, because the computer will be kind of able to pick up tumor as hotspots, and you'll be able to do so much more, like zoom in, into really high power, and then select areas to send off for genetic testing, or share these images with your colleagues, or send them away for opinion. So the possibilities are immense. And of course, AI is again making things so much more efficient and wonderfully kind of easy to do. So AI is getting into pathology and histopathology in a big way as well. There's precision medicine, which means that every patient is going to be treated differently depending on the genetics of the tumor and the genetics of that person. So that's precision medicine. So it's there, and histopathology plays a very important role, because we kind of choose the tumor tissue that will be sent out. We kind of decide what kind of genetics we want on that tumor tissue, depending on the recent literature, which says, for instance, HRD testing in high-grade serous carcinomas of the ovary, because that can help to kind of put patients into the category where they will be eligible for PARP inhibitors, and that will really improve their prognosis and their quality of life. And then you have excellent high quality online resources. So this is the pathology portal, which has recently been launched in 2023 by our erstwhile college president, Professor Joe Martin. And this is going to be an excellent innovative resource to deliver high quality educational material that can even be customized to individual needs. So exciting stuff there. And I thought nothing summarizes my talk better than this slide that showcases the winners of the Royal College Art of Pathology Competition 2023. And just kind of because it shows what the public really thinks of pathology, and it's really very heartening to see that they think of us as the wearer of many hats, as dealing with pathology from head to toe, which is so right. Pathologists probably know much more about disease pathophysiology, because we know most what goes on in most of the body, and how to correlate the pathology with the clinical symptoms, and how patients get impacted by the practice of pathology and the reports that pathologists give. So I thought this is kind of the best way to summarize my talk. And I hope you all enjoyed it. We need you in histopathology. There are enough and more vacancies, and I hope some of you do step in to fill those. Thank you.
Yep, we already have quite a few questions. So the first one's more of a general one, and it's a two-parter. So the first part says, are there any short textbooks that you'd recommend as reading material to learn more about histopathology? So if anyone would like to answer that.
For our ST1s in the department, we usually recommend Malavi. I think it's the practice of surgical pathology by Malavi. It's quite a slim book, but it's a really good intro to the topic, because I'd had no histopathology experience before I started my ST1 training. So yeah, that I think that's quite a nice kind of base level introduction.
Right. And I would like to recommend Robin's Basic Histopathology. So that has like half of it is dedicated to basic pathology. And believe me, it makes for such interesting reading with excellent color illustrations, and it kind of gives you a really good base about understanding genetics, about membrane receptors and stuff like that. So it will give you there's a whole chapter, I think, spanning about 17 pages just on neoplasia. So that kind of gives you a very good insight into how we are going to tackle different cancers, where are the potential, targets for therapies, things like that. So that is one. And the second, for a little more advanced systemic pathology, I would say Rosai and Ackerman's pathology, which is in 2 volumes.
Okay, thank you. That's great. And there's quite a few people asking questions about experience in terms of adding it to a histopathology application. So does someone want to talk in like what would be useful in a histopathology application?
It is really difficult to get experience, like because obviously we don't get people I mean, obviously all universities are different, so we don't necessarily get people kind of coming through the department. If there is like an option for you to do like a selected study module and your local pathology department offers that, that's always really helpful. But I think, I mean, I don't know if I'm wrong about this, but I think most histopathology departments are incredibly friendly. And actually, if you kind of reach out and just say, look, I'm a student at the local university, I'm really interested in histopathology, I'm struggling to get information about it. Have you got anybody who would be willing to kind of talk to us, or even just show us around the department or something? I think that is a way to do it. And obviously, if you've got a local pathology society, that is obviously probably one of the first places I would probably suggest getting. I think when you're a bit kind of further on, like during your F1 and F2 placements, I think it's a little bit more formalized, the way that you can kind of like apply to do a taster week and things like that, and that is usually enough to go on the specialty application form.
Yes, I agree with Steph. That's true. We've had a few FY doctors come in for a week or 2 weeks of taster weeks, and they've kind of been exposed to everything from cut-up to MDTs. And not only do they get a flavor of everything, but they can put it up in their application, and it will be really useful if they can come up with some kind of a small little pilot project that has some component of pathology in it. For instance, like something very like basic but patient centric, something like transport of, let's say, pleural fluids into the lab, and how to reduce time and how to reduce things that can cause the specimens to disintegrate, and refrigerating them, or make a small little pilot project that can help to show that you have an interest in it and you have thought about a problem and tried to look for a solution from your end. That should really help.
Yeah, thank you. And just based on what Steph said as well, I know as a society we're trying to get people's experience in the labs as well. So we're trying to work on that and getting students to experience more of what a pathology lab is like, because I know it's not really experienced by many students. Okay, there's also a couple of questions asking about drawbacks to being a histopathologist.
I mean, yeah, any medical career is going to have that. I mean, it's difficult, isn't it, to say, oh, it's quite stressful, but every medical career is quite stressful. I think sometimes there is a little bit of a mismatch between kind of the expectations of the clinicians and the reality of what we can do, and that's more of an education problem, I think, in the sense that I think because a lot of people don't have experience of working in histopathology, they don't know how long it takes to receive a specimen, process a specimen, do all the paperwork associated with the specimen, and then actually look at it and decide what it is. So I think there can be unnecessary pressure sometimes from kind of outside sources who maybe don't understand that actually this isn't something I can just answer like that, and it needs a bit of time. So I think that is probably one of the downsides. And I think as well, we can be a little bit under-resourced in the sense that obviously a lot of hospitals are kind of prioritizing getting people through waiting lists and things like that. So they run a lot of like extra clinics and things at the weekends. But unfortunately, that doesn't always translate to them providing us with more services so that we can then write reports on those cases. So I think sometimes we are a little bit kind of forgotten in the chain sometimes. But they would be the only things I can really think of personally.
Yes, absolutely. I agree. It's like sometimes, the pressures from the clinicians. And that's where I've learned from some of my senior colleagues about, the importance of having that very good kind of rapport with your clinicians. So maybe, meet up with them outside of work where they are also less pressured, and kind of have that good rapport with them where they are able to understand, because it's true, most of them don't. And many a times I've seen my senior colleagues kind of invite the surgeon in to do the cut up of a very difficult case, just, so they know as well that though we do photograph, but sometimes when they come and see that, yes, I believe you, that you didn't find as many lymph nodes as I expected you to, and things like that. So that's something we do need to cultivate as pathologists, because we cannot work in isolation. That's true. And we will not be appreciated if we work in isolation. So that's there. And of course, the rest is all time and resource pressures, which I think the entire NHS is facing, and histopathology is no different. Yeah.
Okay, thank you for that. So another question about the subspecialties of histopathology, and did you get to try them out before deciding on histopathology? So, Steph?
Sorry, yeah, I was going to say, I think
Okay.
it sounds like Aneeta's had a much broader experience than I did in my training. Because, like I say, at medical school, I had no training in pathology at all. So when I was personally looking at kind of career options, it was always just histopathology, because that was the most kind of adjacent to surgery. I was aware that there were things like, kind of chemical pathology and things like that that you could go into, but I'm going to be honest, I didn't look. I honestly didn't even consider those as something for me personally. So I'm probably really not qualified to talk about the other subspecialties, I'm afraid.
Yes, so I had this opportunity to kind of be a so-called a very general pathologist. So I used to do microbiology, hematology, cytology, gynae cytology, FNAs. So in India, the pathologists do the FNAs. And so all of that. But yes, my interest was kind of, going towards histopathology. And that's why I decided to take that up. And then when I joined here as a specialty doctor in the NHS at a DGH level hospital, that's when you actually get exposed to all specialities, right? So at the DGH level hospitals or labs, you get kind of the entire array of specimens. It's not just specialized. So you end up seeing everything from skin to gynae to, cervical biopsies and breast, cores and everything. And so the best thing would be to probably start there and see what kind of interests you. Like, people love lung pathology, but then there will be other histopathologists who say they find it very stressful because it's very limited material to work on. And, you're always kind of trying to conserve material for genetic testing. So it's then it depends on, what kind of takes your fancy. So for me, it was gynae, because I just liked the fact that I could kind of contribute in some way to women's health, I think. So it was breast and gynae for me. But I would say that, if you go to DGH level and then do all the specialities and then see where your interest takes you, and then accordingly you can move up to a more tertiary level hospital where they will do more complex surgeries in that specialty, and then you will get more confidence that way.
Okay, thank you. Sorry, I couldn't unmute for a second there. So we are a little bit short on time, and there are a few other questions. There are a few of them that Zainab's answering as well in the chat, mainly about certificates and things. But just a quick one about any resources specifically for interviews for histopathology that you can recommend.
That's a good question. I think the Royal College website's got a lot of information on that will be really useful for interviews. I honestly think the best thing to do is talk to your local histopathology trainees. So, you know, if you have junior trainees in your local hospital, like regional hospital, they're the best people to speak to because they've just gone through it. If this is something that maybe you don't have access to, again, if you just kind of, usually I think a lot of postgrads in the hospitals have kind of contacts in the various departments. They'll probably have somebody in your local department who has like an interest in teaching and can actually talk to you. I think it's one of those things that it's best to actually chat to somebody about, rather than kind of have like a list of kind of this is what they're going to ask and things, because also I'm out of date now, so I can't exactly remember. But I think the junior trainees are probably like the ST1s and 2s are the best people to speak to because they've literally just gone through it.
Yeah, I'll go with what Steph says. Sorry, I have no experience in that regard.
No problem. Okay, and there's a few others about the latest technology and AI in pathology. So if you wouldn't mind answering a couple of those. This one is just about how do you get trained using the latest technologies in pathology?
It's really topical, actually. I was really listening with interest to Aneeta's because we are just about to get digital. We haven't got it quite set up yet, so it sounds like we're a little bit behind you guys. So it's very exciting at the moment. Short answer is that someone from the system who is providing you digital pathology will come in and teach you how to learn the system. Yeah. That is essentially what happens. Someone from, you know, the company. IT. Yeah, IT will basically say this is how you use it, and then there'll be kind of like online education modules and, like we say, you were talking about validation sets and things like that. So you're not just kind of left to play around with it and hope that you know how it works. They do like this. They do kind of set up education modules and accreditation and things like that.
Yes, it's all in a very systematic manner. Like for our digital pathology, we have a separate digital pathology team. We have a consultant who's in charge of the digital pathology. So she kind of makes sure, you know, what cases go out and how we revalidate. And then she takes, we have to fill up forms when we look up digital pathology slides and say whether we found them difficult, whether we found them easy, whether, you know, our diagnosis on the glass slide and on the screen, was it concurrent or not, and things like that. So then she kind of collates everything, and then she identifies the problem areas. For instance, there might be things like people say, oh, I was not really able to see the mitosis very clearly, or, you know, so it also depends on obviously the what do they call it, pixels or DPI as the terminology. So it all depends on what kind of technology obviously the department has. So you need to have obviously the heavier the technology and the software that you have, you will get better resolution. Your slides won't hang. You'll be able to zoom in and zoom out, and you'll be able to share slides. So all of that, it's all quite like in the teething stage still. We are not like still there, but the good news is that we're all kind of putting in the effort with the distant dream of working from the Bahamas one day. So yeah, so that's where we are right now. So there's enough and more support available. You will not be left in isolation. That's the bottom line.
Okay, thank you. And can anyone answer about post-mortem training specifically and what it involves?
Yeah, so for the run through histopathology training here, so in your kind of first year, all the training schools, like in the different deaneries, are slightly different. So I can really kind of speak from like a Northwest Manchester perspective. But you essentially get trained in how to do a post-mortem. And by that, what I mean is that you work quite closely with the anatomical technicians in the mortuary, and there'll be a consultant, or hopefully more than one, there'll be a few consultants in the department who will also do post-mortems as part of their regular work, and they should hopefully have oversight of training, and it will kind of take you through the procedure itself and how to kind of formulate the reports and what kind of paperwork you need to provide to the coroner and things as well, because that's another big part of it. In terms of the practicalities, you have to do 20 postmortems in your first year and 20 postmortems in your second year as a kind of minimum. And then after your second year, and once you've got your part 1 of the FRC path, if you don't want to continue with postmortem training, it then becomes optional after that. So if it's something that you really are not keen on, you've just got to kind of get through it in the first 2 years and it's done. If it's something that you're interested in, which is brilliant, because it is really, really rewarding and a really excellent educational experience, you've got the option to kind of continue on with that. And that if you then want to go on to practice that as a consultant, it's a separate exam, but you can kind of take that towards the end of your training.
Great, thanks. Sorry, just one thing. I have put this on the chat, but just in case anyone hasn't seen, about the questions about the certificates. Rosie and I aren't actually Royal College of Pathologists, so we can't issue certificates like formal ones. And Penny's unfortunately had to go, but we can forward the question on to her. And if the Royal College is able to issue attendance certificates, then rest assured we will email them out to everyone who attended. But yeah.
Okay, there doesn't seem to be any more specific questions. So thank you to everyone for joining. Sorry we ran over a little bit.
Yeah, thank you.
But it's been a very good talk. Thank you, Steph and Aneeta, as well.
It's
been
been
very
great.
good.
Thank you so much for having us. Like I say, this is just such a good resource. I wish I had something like this when I was at medical school.
I agree, Steph.
Yeah.
It was lovely collaborating with you all. Thank you so
I'm
much,
actually
Rosie,
email you.
Zainab.
Yes, thank you so much,
about
both of you.
pathology. Yeah, I've got some questions about how you do that up there, so that'll be really helpful.
I think
Sure,
this is really
anytime.
good. I think this is really good for medical students, especially because over the past, few years, decade, pathology has grown a lot. There's been lots more research done, and it's really great to actually get students involved in that now, and kind of in a way that other specialties have been doing for a bit longer. But it's really nice. Your talks have been really good, really fascinating, and also it's been really nice to have you clear up some common misconceptions and stereotypes. But yeah, thank you both. And just for everyone still watching, please follow us on social media and subscribe to the YouTube channel.